Hello, I'm Dr. Randall Siegrist, your host for eOrthopodTV. And today we're talking once again remotely with Dr. Erik Nilssen. Dr. Nilssen is an orthopedic foot and ankle surgeon who practices in Gulf Breeze, Florida. Dr. Nilssen did his medical school training at the University of South Florida and from there an orthopedic residency at McGill University in Canada. Dr. Nilssen completed 2 orthopedic fellowships at the American Sports Medicine Institute, one in sports medicine under the direction of Dr. James Andrews, and one in orthopedic foot and ankle surgery under the direction of Dr. Angus McBride. Thanks for joining us today, Dr. Nilssen.
Thanks for having me.
Well, Dr. Nilssen, today what I thought we would talk about is a fairly common problem in the foot and the ankle, and that's stress fractures. And, I think everybody's comfortable with the notion of a broken bone and a fracture, but stress fractures are a little bit different. So let's start out by talking a little bit about what a stress fracture is.
Well, a stress fracture, if you break it down, a very, very common injury that we see a lot of as foot and ankle surgeons. But, a stress fracture is, in layman's terms, is really an overuse injury that can occur in any bone. Okay, we think of fracture as a bone that breaks in two. A stress fracture is not really quite like that. It technically breaks, but it breaks in such a subtle way, it's very difficult at times to diagnose, or even as a patient even knows what happened. But it's basically just a subtle break in the bone, and there's a lot of etiologies, risk factors, or really in the pathophysiology of stress fractures that we'll go into probably in the next couple minutes. But it's an overuse injury, which is a subtle break in the bone.
Yeah, it's interesting. I like to describe it. It's sort of like bending a paper clip. The paper clip, you can bend it 1,000 times probably, but eventually it wears out and will go ahead and break. And in some ways, bone tends to function in the same way. We think of bone as either it either breaks or it doesn't, but bone tends to sort of be pretty resilient if you continue to stress it. But eventually you overcome its ability to try to repair itself, and eventually it's going to break if you just keep doing that fast enough that it can't repair itself. And I don't know what analogies you use with patients, but that one seems to always strike patients as something they can understand.
I think I'll use that same one. It's a great one. It's not to get too technical, but there's a term out there called Wolff's Law, and we don't want to go too much into that, but the way bone really works is it remodels in response to stress. And so if you think about it, in terms of an abrupt change in frequency, intensity, or duration of running or jumping, bone is very dynamic in the sense that it remodels. So bone just isn't a static, organ, if you will. It's constantly remodeling and resorbing itself. So bones being laid down and bones being taken away, and it's kind of like nature. There's a real balance here, and so that race between bone being taken away and bone being laid down has to be really in perfect synergy. And so when someone overuses, or say someone's working out twice a week versus 7 times a week, well, the body needs something very important called rest. And so when you don't rest, that imbalance sort of gets thrown off, and maybe it resorbs too much and it doesn't have the ability to lay down enough bone. And so you get these little micro fractures constantly loading it, and then the bone eventually breaks or bends like that paper clip.
Yeah, agreed. It's a great analogy that people just can focus on and sort of understand what we're talking about when we talk about stress fractures. What type of patients do you see that come into your office with stress fractures?
That's a great question. I mean, we read, and you just think that just athletes get stress fractures, and they certainly do. I personally see a full gamut of patients. I've seen as young as 9 to 10 years of old, just a sort of a weekend warrior type. So someone that kind of wants to be active, plays basketball. I've had 65, 70-year-olds that don't play basketball, aren't even that active, and just from simple walking can get stress fractures. Of course, we see high-level athletes as well, both high school, collegiate, even professional, which demands a lot more attention just because of the fact that it's important that they get back to play and in sports, and that comes a whole other issue. And of course, we see, living where I live in Pensacola, there's a lot of military bases around here, so we see a lot of military patients as well. So I see the full gamut, which if you summarize all that, everybody can get a stress fracture. Every bone can get a stress fracture, but there are some patients, if you will, or certain types of activities that lean more towards getting a stress fracture.
And what about in the foot and ankle? Where are the most common locations for stress fractures? Can any bone in the foot and ankle be affected, or are there more common bones in the foot and ankle that you typically see stress fractures affect?
Yeah, certainly. I mean, every bone can be affected, but the most common bone in the foot and ankle that I see, or we typically see, are the metatarsal bones, and those are the long bones really in the forefoot. And those are the most common, and classically you see it in the second metatarsal most commonly. I'd say that's number one. Behind that, I'd say the heel bone. And if you go up a little bit higher around the ankle, you can get stress fractures as well. Along the medial malleolus, even the lateral malleolus, or when you break an ankle, those bones, even the talus, which is the bone that houses the ankle joint itself, can get it. But the real big ones are the metatarsals, and even the toe bones, or the phalangeal fractures, stress fractures. I've seen those as well. Those are much less common, but metatarsals for sure is what really brings everybody in. And I've even seen the midfoot bones, cuneiform, or even the cuboid bone. I've seen a few of those, which are quite rare. But again, all the bones involved, but the biggest thing is just getting to the diagnosis and getting it treated.
And let's talk a little bit about symptoms. What type of symptoms do patients present with in your office that leads you to suspect that the patient may have a stress fracture?
Well, the history is really key for me. Patients come in and they say, well, my foot hurts, okay? And so that's usually what brings them in. But usually it's this sort of insidious onset. It's been kind of hovering for about 2 to 4 weeks. And I usually ask the question, hey, was there a change? Are you active? Yes, I'm active. I run, or I go to the gym every morning, whatever. Was there any change in intensity, duration, or frequency of your training modalities? Did you do something new? And they'll say, well, most likely they'll have some sort of change in their exercise pattern. And if not, then we look at other things like, did you buy a new pair of shoes? Because equipment can play a role in it. Well, I used to run on a gravel track for the last 10 years, but over the last 2 months I started running on concrete now. So I mean, equipment or surfaces that they're running on, or I started jump roping a few weeks ago. So those are the kinds of things in terms of a history to help lead you down this path. But in terms of physical exam findings, usually, it's really, if it's a metatarsal fracture, it's usually pain along the top of the foot, and they've never usually had it before on first-time presentation, pain on the foot, and they can usually pinpoint when you do a physical exam. I mean, you just methodically, follow along the metatarsals, and usually you can hit that spot of most tenderness, and there's not much else that lives there, and get it on a physical exam. But there's also some other things in terms of history that like I said, training patterns, change in footwear, and even there's some nutritional issues too that you want to make sure of. I mean, dietary habits in terms of vitamin D and calcium, because we know that those play a key role in fractures and fracture healing. And so you want to get a good nutritional history. And also, with females, hormones play a big deal. So you want to talk about menstruation and menstrual cycles. Are they on a regular menstruation every month for females? And also metabolic states, in terms of, past medical and past surgical history. Do they have some GI surgery or lap band surgery where they're not really getting the foods that they need that are high in vitamin D or calcium? So those are things you want to check into too. And, really I look at, there's kind of 3 things that I kind of bunch together. There's, mechanical symptoms or mechanical issues, hormonal, and nutritional. And if you kind of keep those 3 things together around your history asking questions and your physical exam, and as you treat the patients in the past medical and past surgical, those kinds of things will come into play, and you can hopefully weed out some of the causes or the risk factors for these problems.
And when that patient presents in your office and you've completed the history, you mentioned the physical exam and essentially trying to figure out where the tenderness is. What other points of the physical exam do you focus on to try to help you make the diagnosis of a stress fracture versus maybe some other painful condition in the foot?
So, again, I usually, my go-to thing is anytime a patient comes, I make sure they're appropriately disrobed and have them stand, especially as a foot and ankle surgeon. I want to just not look at the foot, and the biggest problem I see is as someone that sees patients on second opinions is they never really looked at the complete alignment. And so alignment, a whole lower extremity alignment, is a very important tool, because we know position of the foot can also cause or lead to an increased risk of a stress fracture. For example, someone that has a high arch or excessive pronators can lead to certain risk factors for them. But particularly on exam, as I look at the alignment, I look at their foot structure, and then the biggest thing I do is as I have them with one finger, I say point, to the spot that hurts the most. And so typically, as long as they have no pain at rest, and usually when they sit down, they're fine. It's when they stand up, and sometimes when they start to actually jog, or it only hurts when I run. So early on in this process, it's just when there's activity going on. But as it progresses, it's usually during their activities of daily living. So they say, well, it just hurt when I ran. I thought it would go away. Now this has been going on for 4 weeks. Now it hurts when I get up in the middle of the night to use the restroom, or I'm in the house getting going, it hurts me. But they point with one finger where it hurts the most. And if it's particularly, as a physician, you got to know your anatomy, but if it's your metatarsals in the forefoot, they'll point right to that metatarsal. And so then I'll palpate around that area, and I'll look for some generalized swelling. And oftentimes you'll see some swelling, occasional bruising, but that's usually early on. I usually don't see a lot of bruising when I see these patients, but there's generally some swelling for sure. And as soon as you palpate on that bone, I mean, they sort of jump in their seat. And so if they had a navicular fracture, you want to really make sure you palpate on the medial side of that navicular and also really dorsally on top. But knowing your anatomy and palpating around the area and looking for swelling is what I typically kind of go to, and I can pretty much hone in on they have a stress fracture.
Well, and then what do? I'm assuming that you normally are going to get some x-rays or something like that of the foot and sort of focus on the area that you feel is involved. Is that your next step, just a plain x-ray?
Yeah, classically, if they come in for a classic presentation like that, I get if it's their foot or ankle, but the biggest thing is get a standing view. So I get a standing view of the foot, which includes an AP, a lateral and oblique view, or an ankle series. That's my first, image modality to go to. And classically, if I get that and you get this, this stress fracture is going on early enough, oftentimes, probably 30% of the time, you won't see anything on x-ray. So again, it's not like you see a bone that's broken in two. They fell off a bike and a bone broke. This is basically a real subtle finding. Oftentimes you won't see a fracture, but you have a suspicion. So in that presentation, I'll get an x-ray. X-rays are normal. Okay, sometimes you get lucky and they'll say, wow, you'll see some early bone remodeling or some cloudy calcification around that area where they were sore, and that helps confirm the diagnosis that they do have a stress fracture. But I'm usually pretty confident in my diagnoses, but if I suspect a stress fracture and the x-ray is normal, there's other imaging to go to. So say, well, what about MRIs? An MRI is a great tool really to confirm the diagnosis, but I hold off on MRIs initially because I feel comfortable enough it's a stress fracture, and they're not cheap, and with healthcare being what it is, and a lot of the onus is on the patient, I'll hold off on an MRI unless I'm treating them, and we'll go into the non-operative treatment of this. But if they're coming back to me in 6, 7, 8 weeks and they're not really responding too well, then I'll go ahead and get that MRI and say maybe I'm missing something here, and say, well, gosh, how do you know it's not an infection or something? But looking for fevers and chills and some type of past, some risk factor for infections. But you start to go back. But right off the bat, I hold off on MRIs. Talk about CT scans. I don't get a CT scan right off the bat either on stress fractures, even though it's a good bony way to get imaging. Some people like to get bone scans. And a bone scan is very, very sensitive for a stress fracture, but they're not very specific, meaning that you could have an infection going on there, or even like heaven forbid, a bone tumor. A bone scan will pick that up as well. So it's not specific to a stress fracture, but it's very sensitive in picking something up, and some people like to order those as well. And if you have a very good ultrasonographer in your practice or to your disposal, you can always send them to an ultrasonographer and they can ultrasound, but that's also very user dependent. And so you have to have a lot of trust in there. But of all these modalities, the cheapest, most inexpensive is an x-ray. So they come in, I get an x-ray, and I have them come back in 2 weeks. I re-examine them again. Of course, if we go into treatments, I'll immobilize them, but I come back for that second x-ray in about 2 weeks to see if I can see any kind of cloudy changes we talked about as it's showing signs of healing or not progressing for that matter.
So if I can paraphrase, one is you've said that you feel like, one, your diagnosis based on the history and the physical exam is pretty good in terms of giving you a pretty good idea that you're dealing with a stress fracture. Then you'll get an x-ray, and as both of us know, x-rays are commonly negative on that first visit. And what I've heard you say is that you feel like that the MRI scan is a better second test than a bone scan, but both are probably acceptable. But also what I've heard you say is that you typically will go on your history physical exam and the results of the x-ray and go ahead and start treating and not go to the expense of an MRI scan unless this condition is not responding to your treatment the way you suspect it should if it's a stress fracture. Is that accurate?
Yeah, that's very correct. And I'll just add one little thing, and we didn't talk about it earlier, but yeah, and I'll classify stress fractures into high-risk stress fractures and low risk. And so if it's a metatarsal fracture, unless it's a base of the fifth metatarsal fracture, which is what I classify as a high-risk fracture, depending on what type it is, then I'll get some other imaging potentially, or a navicular fracture, because a navicular fracture we're going to treat a little bit different than we do a metatarsal fracture. So in general, depending on the type, if it's a high-risk stress fracture, we may seek some other second tests more immediate, but generally speaking, what you said is very accurate for general low-risk stress fractures.
And what about lab tests and those sorts of things? Do you see any need to do any sort of lab test, blood test, anything like that to rule out other disease processes?
Well, I think it's a great question, and there are some physicians out there, and there's some centers, I think even like Mayo Clinic, there's some doctors that, anytime someone walks into their office with a stress fracture, they send a consultation into a metabolic bone disease specialist. And that's what they're, sort of trained to just deal with all these types of the various metabolic issues. But I think, I'll often just order a basic serum, which is a blood or even a urine. We'll check for calcium, albumin, alk phos or vitamin D levels. And there's some good studies out there, even from the trauma, from a trauma perspective, patients having mega traumas and multi-trauma, polytraumas, making sure that their vitamin D and calcium levels are adequate, because oftentimes they're not, and they're malnourished, and so the fractures take longer to heal or go on to a non-union. So, stress fractures, to really optimize care, I think, is it cost effective to get all these blood works on every single stress fracture that comes in the door? Probably not, but I do. There are definitely blood levels and urine levels, and even checking kidney functions. But the most inexpensive, easiest way is a calcium and a vitamin D, or even that matter, you could recommend putting them on it. And I often say, hey, are you taking a multivitamin? But oftentimes that's not enough, and so I'll tell them take 1,200 to 1,500 milligrams of calcium a day, and it's like between 800 and sometimes he'll recommend 3,000 international units of vitamin D per day. But that's sort of physician dependent. But to answer your question, I don't get blood values on every single patient, but I think you certainly can't argue to do so.
Well, it sounds like you're in the habit of separating stress fractures into these low risk versus high risk. So let's talk about the low risk, like the metatarsal stress fracture. And let's talk a little bit about treatment and what a patient can expect from treatment of those low risk stress fractures. How do you treat those?
So, for the low risk ones, again, it's just to generalize, it's going to be sort of a rest and immobilization. And so for a low risk fracture, they come in, tell them what they've got, and the biggest thing to treatment is informing the patient of what exactly their problem is and give them sort of a timeline. So, someone's had no treatment, classically comes in, 4 weeks have been hurting, and it's a metatarsal low risk stress fracture. I will, go through the whole gamut, tell them what it is, but I'll put them in a walking pneumatic boot, those little ski boot looking deals. I won't cast them. I'll put them in a boot and tell them you can walk in your boot or drive through your heel. If it hurts, your foot hurts, then you got to use crutches. If it doesn't hurt, you're not harming anything, use your boot. And I say if it hurts, no matter what you do, don't do it. So, that's pretty simple, but they're really immobilized in a boot. That's the biggest thing. They don't sleep in it, and that's the immobilization that I usually do. And then on top of that, on a side note, which is often missed, is I'll go back to that sort of pyramid I'm talking about, mechanical, hormonal, and nutritional. And so I'll run through, I've got them immobilized, they're going to rest, I'm going to activity restrict them. So, you know, you got a cross-country runner who's got a metatarsal stress fracture, and very hard to get that person to not run for, you know, 6 to 8 weeks or longer. And so they'll say, well, can I swim? I'll say, well, if it doesn't hurt, you can swim. Or maybe ride a recombinant bike or something. They can do some activities or some weight training upper body as long as it doesn't hurt their foot. So immobilization, rest. Nutrition-wise, I'm thinking, well, does this person have any vitamin D problems? Do they have any calcium problems? Make sure that's optimized. Mechanical alignment, you know, are they, like I said, are their arches really, really, really high and they're stressing the outside of that foot? That's why they have a stress fracture. Do we need to get them some kind of orthotic when this thing heals? Or maybe some shoes with some lateral inserts to kind of offload that, or vice versa. And then if it's a, you know, a female, you know, that has you know, hormonal issues, or, you know, amenorrhea, or they're not having their monthly menstrual cycles, getting them into the hands of someone that can help deal with that. So those are sort of my first line low risk treatment patients is what I do.
And how long do you think that it takes for a stress fracture to heal in that scenario? I mean, a patient who comes in with an uncomplicated stress fracture, none of these metabolic or other reasons to suspect that this is a more difficult to manage stress fracture, how long is it going to take them to heal this where they get back into their normal activities?
Yeah, I'd say, you know, if they follow directions appropriately and they're immobilized in that boot, usually they're in a boot for about 4 to 6 weeks, you know, more on the 6-week part. It takes a while. And I transition, the reason why the boot works is because the heel and the toe are so stiff you can't bend it. And it takes pressure off the foot. And I'll transition them into a shoe, and I'll say, go to your closet, take your heel and your toe, your shoes, and squeeze them really hard. And the stiffer the shoe is, that's the shoe you want to be into, transition out of the boot. So it's basically boot for 4 to 6 weeks, and then at the 6-week mark, if they're feeling pretty good, and they can walk in a shoe without any pain. So it's really that crawl, walk, run scenario. You crawl before you walk, before you run. And so they make a step into a shoe and they can, you know, withstand activities of daily living. So I say you've got to be able to go 2 weeks out of a boot into a shoe with activities of daily living, walking, you know, carrying the kids and going to work and all that good stuff. And then at that point, if they're completely pain-free, you know, they can ease back into some, you know, a light jog or some things they were doing before, but at a very, very slow rate. So I mean, it's not something they're back running in 4 weeks. It's usually 8 to sometimes 12 weeks after they have a stress fracture, because even though it's a pretty subtle fracture, you'll see x-rays at the 8 and 10 week mark, there's sort of a nice big callus of bone around it as if it was a major fracture from the beginning.
So it's a real broken bone. It's not a less of a broken bone. And I think patients need to take away that a stress fracture is just as serious as a regular fracture. It takes the same amount of time to heal.
Correct. I mean, absolutely.
Okay, high risk. What are the high risk fractures in your opinion?
You know, the most common high risk one that we typically see are you know, base of the fifth fractures. And so I've got a model here, and so a base of the fifth, this is the foot from the very front, and then this is the fifth metatarsal. So the base of the fifth is sitting right in this area. And so those are subclassified, and some are just avulsion fractures, and those can be treated as a stress fracture non-operatively. But you know, a stress fracture or a fracture at the base of the fifth, I consider sort of a high-risk fracture. And these are high-risk fractures for really one reason. It's because of blood supply. And anytime you break a bone or injure something, all the healing factors to heal that are from blood. And so, you know, it's like a water hose in a garden. You know, if the tree or the plants aren't getting water, you know, they're not going to heal. And so imagine having, you know, 2 adjoining fields and a sprinkler from one side and a sprinkler from the other side, and where those sprinkler heads hit, that area in between is kind of this watershed area. And that's an area where the blood supply is not the greatest. It's still getting water, but it's not the greatest. Same issue with this base of the fifth metatarsal fracture, is where that blood supply in that area just isn't great. And it can heal, and there's blood there, but it's not like the rest of the bone. And so those are considered that's a high-risk stress fracture. And same thing with the navicular bone. And the bone, here's another picture of this model. This is the navicular right across here, and you know, as the ankle goes up and down like this, you know, this bone sort of adds it's a sort of a link between the forefoot and the hind foot. That same scenario, there's blood supply from either side, and right along the center of that bone, the blood supply is not the greatest. And so that's classically where you get this stress fracture. And these are high risk because we don't just see that fracture and go, oh, well, put you in a boot like we did low risk fractures. Those are ones, especially with a navicular fracture, we're concerned about. I'll go ahead and get that MRI or CT scan because I want to see if that fracture line goes all the way through that bone. And if it goes all the way through, we're more aggressive and we start talking about surgical intervention at that point. Other high-risk stress fractures, I would say, are really in the foot and ankle, or talus as well. But the navicular, pertaining to just the foot, the navicular base of the fifth, and then kind of a tweener in between are sesamoids, and we don't often talk about those. And these are the two little bones in the bottom of your first big toe. There's a medial and a lateral, and they're very much like having, just like your kneecap in your knee. Very important bone structures, often overlooked, and those things can get stressed as well. And I see a lot of that. Oftentimes they come in and the bottom of their foot hurts, and it's those medial or lateral sesamoids, and those can be very problematic, can have stress fractures that can lead to loss of blood supply. They can become avascular, and you got a real problem on your hands.
Let's talk a little bit about the base of the fifth metatarsal. And you mentioned that you may be more prone to go to surgery quicker with that fracture, the same with the navicular. But let's focus right now on the base of the fifth metatarsal fracture. What drives you to have a discussion with the patient that says, we need to consider surgery?
The biggest thing is, I talk to the patients and say, well, again, and it's very challenging and difficult to try to treat an athlete different than, a non-athlete, because you can say, what defines an athlete, what defines a non-athlete, and it's a challenge. But I try to say, well, I'm going to treat everybody just the same. And I'll tell you that with athletes, especially high-end athletes that we treat, they want to get back fast, and these, it's pretty public knowledge, but I mean, Yao Ming retired from basketball. This is what he had. Grant Hill missed those couple years in basketball because of the base of the fifth fracture. So what's considered kind of a no big deal is really a big deal. And so, things that I say are, how active are you as a patient? Surgery now, it's a fairly straightforward surgery to do. It's very easy, but again, it's surgery. But I kind of lay out, hey, if we don't do surgery, the risks are, it could become really a complete fracture, or it can never heal. The proximal piece can die. But they always end up asking me, well, what would you do? And it's hard to answer, but I'd say that, looking at each patient individually, I really do. And I say, how active are you? What kind of things you like to do work-wise? And even now, a lot of patients are making their decision. It's really, really sad based on financial, hey, I have a high deductible, I can't afford surgery. And that's a tough pill to swallow, even as a treating physician.
So what I'm hearing you say is that if you have a patient in your office, and let's say they're a high-end athlete, or maybe they're just a very aggressive amateur athlete that wants to get back as fast as possible, am I hearing you correctly in saying that when you see that base of the fifth metatarsal fracture, you may not even try conservative treatment, you may opt to recommend surgery as soon as you see that fracture?
Yeah, I mean, if it's a complete, we call it, the mnemonic is sort of a Jones fracture. If there's a complete fracture line that I see that kind of goes into the 4 or 5 interval, that's a true Jones fracture. I'm very aggressive in that, and we actually, we used to even treat it with just a cannulated screw, but we use a solid screw now. There's really good data and literature out there where we're actually aggressively fixing those at this point today, and I'm aggressively going to say, hey, if that's mine, it's a Jones fracture, I'm going to fix it, and I want that fixed. And so I will go right to surgery on a base of the fifth Jones fracture. If it's an avulsion fracture, or truly just some edema in the bone, like a mild stress fracture, I won't go right to surgery on that, but I will be aggressively in immobilizing that patient. So if they have a base of the fifth fracture that's the cortex isn't really fractured, just some edema in there, like it's an early stress fracture and they're hurting real tender, I'll go ahead and put them in a cast and go non-weight bearing for at least 4 to 6 weeks. And there's some really good studies out there that those will heal, because you put them in a boot and all it takes is one misstep, and now you've got a complete fracture, and now you really have to jump on surgery on that situation.
And I'm assuming that this is outpatient surgery. You're talking about putting a screw just sort of right down the tubular inside of the bone, and that's done as an outpatient?
Correct. It's an outpatient in a surgery center classically for me, or even in the hospital. But it's a you know, from start to finish, it's a 20-minute procedure, and it's about a little half a centimeter poke hole. That's all it is.
And what about the navicular fractures? How do you deal with those? When do you start considering surgery in that type of stress fracture?
So in that situation, you know, along the same lines, if, you know, navicular stress fracture, I suspect they have one, very hard to see on plain x-ray, you get an MRI. And so scenario one would be the MRI shows that the navicular, there's just a lot of stress reaction in the navicular, but no real defined, you know, cracks, if you will, or defined lines. And so you get a CT scan after that to make sure there's not any hidden lines. And there's no hidden lines. It's just really, it's like someone took a hammer and just kind of bruised it. In that scenario, aggressively immobilization, put them in a cast, get them off their foot, and that takes a long time to heal. You know, I've had cross-country runners that I take care of at a college, and you know, you're talking, they don't run for 4 months sometimes. It takes a long time. Scenario two would be that same scenario, but they have a line going right through the middle of it. We call it sort of this dreaded black line, right down the middle of that navicular bone. CT scan shows a crack straight down the middle. I'll jump to surgery on that, and I'll classically put 2 screws across that navicular bone, and some people actually open it up and try to put some bone graft in between that line and put screws. That's sort of user dependent, but I'll classically just put 2 screws across that thing to get some compression and, you know, hopefully get blood from one side, blood from the other side, to kind of help interdigitate across and get what you hope to get a fusion. And you're trying to avoid is that bone eventually crumbling and dying, and then you've got a serious issue on your hand.
And so if that fracture heals with the 2 screw technique, how long do you typically keep people off their activities?
Yeah, so if I'll do that, it's going to be, you know, they're classically non-weight bearing for about 6 weeks with that scenario, and then at that point they'll go into that boot we talked about earlier, and or maybe a boot at 4 weeks, but I'll keep them off it and they'll start moving their ankle up and down and get some motion back. But they'll start walking in a boot at about 6 weeks, and they'll classically have that boot to protect them for about another 3 to 4. So at 10 weeks, oftentimes, and some people will well, let's get another CT scan at that point before they let them kind of get back to things. But just to make sure that thing's healing, because x-ray sometimes will fool you. But again, you know, the issue with that is that bone especially, it's a slow bone to heal, and you just don't want to risk losing that bone to get them back quicker. So again, a navicular fracture, you're probably looking at a good, you know, probably 3 months, 4 months before they get back to full activities.
And what about the screws? Are you going to go back and take the screws out, or do they stay in place?
I classically just leave those in. You know, we classically just leave the screws in, and they're so, you know, they're low profile, you really can't feel them, and I'll leave them in. On a rare occasion, if they say they have pain where the screws are, you could always argue to take them out, but then you got these holes, and you got to kind of protect them again because those got to fill in with bone. So I just assume classically leave them in. I've never really had to take them out for pain around the screw site.
Well, this has been a fascinating discussion about stress fractures, both the low-risk stress fractures in the foot and the ankle and also the high-risk fractures. Do you have anything that you feel like patients should know that we haven't discussed up to this point about stress fractures in the foot and the ankle?
You know, a couple things. I would just, you know, depending on, you know, where you're living and who's treating you, I think it's really important to understand the concepts we talked about already. I would suggest, you know, if you just get a basic kind of a low risk stress fracture and you're being treated and it's not responding, seek a second opinion. I would suggest too, for the older patients, you know, bone density testing can also, we did talk about that, can be very helpful in preventing future stress fractures. You know, I get even a 58, 60-year-old relatively young patient comes in with a stress fracture and they've never had any kind of metabolic testing. It's kind of nice to get that as a baseline. I think more and more patients are living longer as well. I think stress or resistance training, I'm not talking about bodybuilding, but you know, putting some muscle mass on, you know, can definitely trick the bone into getting stronger. I did that with my mother. People don't think about that or prescribe that, but I say get active in a gym and put on 5-10 pounds of muscle, do some bodybuilding. That will definitely help prevent osteoporosis and other things as well. Make sure your diet is optimal. Even a nutrition consult, do some blood work, check your vitamin D levels, calcium levels like we talked about. getting with them. If you're having a repetitive history of stress fractures, there's got to be something going on, and think about the hormonal aspect of it. Make sure that's, you know, adequately treated, nutritional aspect, and then mechanical. Very few physicians are going to look at the lower extremity and really check out, make sure your knees aren't knock-kneed, make sure your hips are aligned, make sure you don't have a leg length discrepancy, make sure you don't have high arches or flat foot. A simple orthotic can help offload that, a knee brace maybe, but those are some things. I'd say, you know, there's some stuff coming out even on TV with the bisphosphonates with the osteoporosis, and you know, there's some studies out there very conflicting. We're taking some of those, and those are for people that are losing bone mineral density out of their bone. This kind of helps prevent the bone from being eaten away and lays down more bone, but using that to treat a stress fracture is pretty controversial. We're not quite there yet, and I think the future, we can probably get into that later, but the future is really, I think, stem cells, and I've done some work in that overseas, are definitely going to be ways to help. How can we get these things to heal better or faster, really from the athletic standpoint, and really from the non-athlete or weekend warrior? How can we prevent them? If you can prevent them, that's really the gist. And so, you know, most people can treat these things appropriately, but get to the root of the cause. You know, try to figure out why did it occur. And a lot of people we overlook that, and we just put them in a boot and say, oh, I'll come back in a couple of weeks. I mean, just run through all the things we talked about, and that's kind of what I think.
Well, I think that's good advice to anybody. One thing I think we probably ought to stress, and you said it early on in this discussion, and that is that with a stress fracture, sometimes you get those first x-rays and they're negative. And you know, if you're getting your care at an urgent care and an ER where perhaps the person that's seeing you is not an orthopedist and is not necessarily thinking about stress fracture, you may want to think twice if you get an x-ray and the physician says, well, there's nothing on the x-ray, because stress fractures don't show up initially in a large percentage of those cases. So I think the one take-home message that I would probably add to what you said is that if your foot continues to hurt, even though you've had a negative x-ray, you probably want to go back and say, my foot's still hurting and there's still something I'm concerned with. Any other comments?
I think that's it. I mean, you know, and you also, you know, anyone else out there, watch out for the female triad, and that's a little pearl we'll throw out there. That's the female athlete that has an eating disorder, that's osteoporotic, and has irregular or no menstrual cycles, and that really takes a multidisciplinary team approach to treat that individual, and that's often overlooked, but we see that a lot on the collegiate effort level with track athletes and everything else, and even non-athletes. But you know, I think it's take ownership of your health, take ownership of your problem. Any concern that something's being missed or you know, uncomfortable with the way you're being treated, get a second opinion. We all make mistakes, including myself, and but I think it's a topic worth learning about, and like, you know, Randall just said, it's a great point. They don't show up initially, and it's that second or third x-rays where you start to see it, and it makes you understand really what happened and how to treat it, and move on from there.
Well, thanks for a great discussion. Look forward to future discussions.
Thanks, Randall. I do too.